All right, welcome to the Explainer. If you are tackling A-level psychology, you'll know OCD is a massive topic. So today, we're going to zoom right in on the biological approach to treating it, specifically drug therapy. We're going to break it all down using the AQA spec, making sure you've got everything you need for revision.
So here's the game plan. First, we'll get into the core science. That's your AO1, your bread and butter. Then we'll look at how it actually plays out in the real world for AO2, and after that, we'll get critical and start picking it apart for those top AO3 marks. Finally, we'll wrap it all up. It's that classic path: know it, apply it, evaluate it. Let's dive in.
Okay, so first things first, what's the big idea here? Well, the whole biological approach is built on one core assumption, that OCD is caused, or at least seriously influenced, by some kind of chemical imbalance in the brain. So it makes sense, right? The goal of drug therapy is to go in and try to fix that imbalance.
Right. Let's get into the nitty-gritty. This is our AO1 foundation, and for these marks, you've got to be precise. So what exactly are these drugs? How on earth do they work inside the brain? And crucially, what's the key research that backs all this up? The main player, the one you'll hear about most, is a class of drugs called SSRIs. Think of them as the headline act. And their whole job is to target the serotonin system in the brain. Now, serotonin, that's a huge neurotransmitter. It's involved in pretty much everything from our mood and anxiety levels to how we make decisions. So how do they actually do that? Well, picture this. You've got two brain cells, and in between them is a tiny little gap called a synapse. Serotonin is like a chemical messenger that has to jump across that gap to deliver its message. Normally, after it's delivered the message, it gets sucked back up by the first cell, a process called reuptake. What SSRIs do is they basically stand in the way. They block that reuptake. This means more serotonin is left hanging around in the gap, able to keep sending its signal. More signal, well, that hopefully means better mood regulation.
And look, this isn't just some clever theory. We've got solid AO1 evidence to back it up. The big one you absolutely have to remember is Sumro et al. From 2008. They did a massive review of 17 different studies and found pretty conclusively that SSRIs work significantly better than a sugar pill, a placebo. And on top of that, you've got genetic studies, like one by Hugh and his team, that also point to this biological link with serotonin.
But of course, it's not a one-size-fits-all solution. SSRIs just don't work for everybody. So what happens then? Well, doctors do have other options. Next up are things called SNRIs, which give a boost to both serotonin and another chemical, noradrenaline. And if those don't work, you've got the older generation of drugs called tricyclics. Now, they can be effective, but they tend to have much nastier side effects, so they're really more of a last resort.
Okay, let's switch gears to AO2, application. It's one thing to know the science, right? But how does this all actually work in the real world with real people? This is where we have to start connecting the dots and really thinking like a proper psychologist.
And here's a really crucial point. Medication is often not the whole story. It's not really seen as the cure, but more like the foundation. The idea is that the drugs can lower the volume on those intense obsessions and compulsions, which then, and this is key, makes it possible for the person to actually get stuck into other therapies, like CBT.
Let's make this real with a quick scenario. Imagine a 17-year-old student. They've got contamination OCD, and it just goes through the roof during exam time. The obsessions are totally overwhelming. They can't focus on revision. It's a nightmare. So a doctor prescribes them fluoxetine, which is a common SSRI. Fast forward a couple of months, and their anxiety has come down. It's more manageable. Now they can actually engage with CBT. They can start to face their fears. You see? The drugs didn't magically cure them. What they did was unlock the door so that the real therapy could begin. And this is brilliant for making a synoptic link, connecting different parts of the course. Think about the behavioral approach. We know compulsions are kept going by negative reinforcement, right? You do the compulsive behavior, it temporarily reduces your anxiety, so you're more likely to do it again. It's a vicious cycle. But if SSRIs lower that baseline level of anxiety, well, that weakens the whole urge to perform the compulsion in the first place. So the drug is targeting the biology, but in doing so, it helps to break that behavioral cycle. It's a great link to make.
You can also make another fantastic link to depression. What's the go-to treatment for depression? SSRIs. So what does that tell you? It kind of suggests that serotonin isn't just about one specific disorder. It seems to play this really fundamental role in how we regulate our emotions across the board.
All right, so we've covered what it is and how it works. Now for the big one, the crucial AO3 evaluation. This is where we ask,
how good is this treatment really? And to do that properly, we've got to look at both sides of the coin, the good stuff and the not so good stuff, so we can come to a really balanced conclusion.
But before we get into a big list of pros and cons, I want you to hold this number in your head. For all the talk about how effective SSRIs are, they don't work for everyone, not even close. For about 30 to 40% of people with OCD, they either don't work at all or they only help a little bit. It's definitely not a magic bullet.
So let's break down this evaluation. On the plus side, the strengths are pretty clear. You've got that strong scientific support we talked about. And practically speaking, drugs are pretty cost-effective and easy to access, which makes them a go-to for health services like the NHS. Plus, like we said, they can open the door to other therapies. But you have to weigh that against the downsides. A lot of patients get pretty significant side effects. We're talking things like nausea, not being able to sleep. Then there's the massive criticism that drugs are just a sticking plaster. They only treat the symptoms, not what's really causing the problem. And on top of that, some researchers worry about publication bias. You know, the idea that studies with positive results are just more likely to get published.
Now, if you really want to hit those top AO3 marks, you've got to evaluate the research itself. So let's use that GRAV framework on the Sumro study. Let's start with G for generalizability. Well, that's a bit of a weak spot, isn't it? The studies were mostly on adult outpatients, so can we really say the results apply to everyone, like kids or people with very severe OCD? Maybe not. But R for reliability is high. They use standardized, consistent measures like the Y-box to track symptoms. A for application, huge. This research is a massive reason why SSRIs are the first thing doctors try. And V for validity is also strong. They used randomized placebo-controlled trials, the gold standard for figuring out if a treatment actually causes an effect. And this brings us to what is probably the biggest, most powerful criticism of all. Drugs are only symptomatic. They're great at reducing the anxiety and the compulsions, but they don't teach you anything. They don't change the underlying thought patterns or address any life events that might have triggered the OCD to begin with. And that means, what happens when you stop taking the pills? Well, there's a very real chance the symptoms will just come right back. Okay, so let's zoom out and pull all these threads together. We've looked at the science behind it, how it's applied in the real world, and we've evaluated its strengths and weaknesses. So, what's the big picture? What's our final verdict?
And it all really boils down to this one question, doesn't it? Are these drugs a genuine cure, or are they just a sticking plaster, something that just covers up the symptoms and makes life a bit more bearable? I think the most sophisticated conclusion, the one that gets you the top marks, is that drugs are an incredibly powerful tool, but they are rarely the only tool you need. The most effective approach, time and again, seems to be an integrated one that combines the biological fix with the psychological work. You use the medication to get the brain chemistry on a more even keel, and that then makes it possible for the person to really dig in with therapy and build the mental skills they need for a proper, lasting recovery.
And that's really the thought I want to leave you with. The real goal here isn't just to make the symptoms go away. It's about empowering a person to truly recover. And that leaves us with a pretty deep question, really. How do we, as psychologists, as a society, as a health system, get that balance right? How do we best combine these different tools to help people achieve a recovery that actually lasts?